Multiple myeloma is a malignancy of the plasma cells and is really part of a family of a spectrum of disorders that we often call monoclonal gammopathies. The most common of these would be monoclonal gammopathy of undetermined significance, smoldering multiple myeloma, and multiple myeloma itself, or sometimes called active multiple myeloma. This spectrum is really important because MGUS, or monoclonal gammopathy of undetermined significance, is incredibly common. In fact, over 5% of all individuals over the age of 40 have an MGUS if we look for it. But a much smaller fraction of patients develop smoldering multiple myeloma, and an even smaller fraction develop active multiple myeloma. Active myeloma, or myeloma, accounts for approximately 1 to 2% of all malignancies, which means here in the United States we see approximately 35,000 new cases per year, and approximately 200,000 individuals are living with multiple myeloma right now in the United States. That spectrum becomes really important to understand the differences between them, because the major difference between smoldering myeloma and active myeloma is where we tend to treat patients and where patients have the classic manifestations of multiple myeloma. It's important to note that myeloma has changed in its definition over the last decade. We used to define myeloma by the presence of 10% or more clonal plasma cells in the bone marrow, plus at least one of the so-called CRAB criteria, C-R-A-B, calcium elevation, renal insufficiency, anemia, or bone disease that could be attributable to those plasma cells. That definition has now changed as we've recognized that we want to catch this disease earlier in its disease course. 3 more features have been added to the CRAB criteria, now known as myeloma-defining events. Often we call these SLIM CRAB to remember them. The S stands for 60% plasma cells or more in the bone marrow. The LI stands for light chains, where the serum-free light chains are elevated, such that the involved over the uninvolved levels, either kappa over lambda or lambda over kappa, are greater than 100. And the M stands for MRI, where we see greater than 1 focal lesion in the bone marrow itself. So if a patient has 10% plasma cells that are clonal in the bone marrow and any of those 7 myeloma-defining events, then the patient has active multiple myeloma. Multiple myeloma is more common in certain populations. We see myeloma twice as common in the African American population. Multiple myeloma is more common in men than in women. And there are other factors that are associated with the incidence of myeloma, which include obesity, the presence of certain exposures that include Agent Orange and certain toxins, and indeed if a patient has a previous or known history of monoclonal gammopathy of undetermined significance, or MGUS, that puts them at greater risk of developing multiple myeloma. Multiple myeloma is actually a very challenging diagnosis to arrive at because patients don't come in with one classic hallmark sign or symptom. In fact, patients typically come in with a relatively vague sign or symptom, of which the top 3 are fatigue, anemia, or back or bone pain. And of course, those are so common in the primary care world. A primary care provider sees that almost on a daily basis, but doesn't see multiple myeloma on a daily basis. In fact, we know from a recent study and multiple studies before it that the average patient who's ultimately diagnosed with multiple myeloma visits their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is suspected and ultimately confirmed. So it really becomes important for us to recognize that as primary care providers, we are the gatekeepers, as it were, of multiple myeloma. Although approximately 2/3 of patients are diagnosed with myeloma through the primary care portal, as it were, there are other ways in which patients are diagnosed with myeloma, which includes nephrology, neurology, cardiology, the emergency department, and even hematology oncology. And so when those signs and symptoms initially present, that fatigue, that anemia, that bone pain, or any of the features of the CRAB criteria with elevated calcium, renal insufficiency, anemia, and bone disease, it is really important for us to pursue the right testing for multiple myeloma. Before I discuss testing, let me also comment that one of the confounding reasons why it is difficult to arrive at the diagnosis of multiple myeloma, especially in higher risk populations for myeloma, like patients of African American descent, like Hispanic patients, is the presence of diabetes. There is a tremendous overlap between the signs and symptoms of diabetes and those of multiple myeloma, such as anemia, such as renal insufficiency, such as proteinuria, or even neuropathy. And so it becomes very important to also suspect myeloma in that patient who we may be attributing these things simply to diabetes. So how do we arrive at the diagnosis of multiple myeloma? Well, we begin with the basics. And so we begin with the CBC. That CBC will provide us not only the hemoglobin level, but of course it will give us the white count and the platelet count to direct us towards marrow function. Secondly, basic biochemistry, which would include the calcium level, the creatinine level to assess renal function, and a patient's total protein to see if there is potentially an abnormality within the protein levels. This then leads us to the myeloma-specific testing. And historically, we've encouraged the use of the serum protein electrophoresis. And it is still a fundamental test and very important to obtain. But without two other tests along with it, it is clearly incomplete, as up to 20% of myeloma patients will not have an abnormality on the serum protein electrophoresis. So along with the serum protein electrophoresis, it's critical to order the immunofixation so we can identify the type and size of that monoclonal protein, but also the serum-free light chain assay. That serum-free light chain assay measures both kappa and lambda levels and arrives at a ratio. And when that assay is abnormal, that may well be indicative of a monoclonal gammopathy and indeed multiple myeloma. So when the serum protein electrophoresis, immunofixation, and serum-free light chain assay are ordered, we know that our sensitivity to detect multiple myeloma is nearly 100%. This is also consistent with the key guidelines that we follow from the International Myeloma Working Group, or the IMWG, as well as the College of American Pathologists, or the CAP guidelines. Both of these guidelines note the importance of adding the serum-free light chain assay to the traditional serum protein electrophoresis and immunofixation. The timely diagnosis of myeloma is very important for patients, both for their short-term complications and indeed their long-term outcomes. We know that this isn't just a disease of numbers. Patients come in with the potential of end organ damage. And in fact, we have changed our diagnosis of myeloma to not wait until a patient has renal insufficiency or anemia or bone disease. We want to try and catch it in such a way that we can prevent those complications. We know that when there is a long delay in a patient's diagnosis, that is going to translate into inferior outcomes and more organ damage down the line. This fits in with our greater interception of malignancies in general, that we always want to catch them at a phase where we can prevent long-term consequences. And so ensuring that we initiate the right tests at the right time in patients that have signs and symptoms consistent with multiple myeloma will allow us to not only make a more timely diagnosis, but indeed to prevent some of those downstream complications that we can see when patients have bone disease, renal insufficiency, anemia, and other consequences that can significantly impact their quantity and quality of life. There was a time not long ago when I trained in myeloma that the average survival of patients was really only 1 to 2 years. Now we anticipate the majority of our patients will actually live more than 10 years with this disease. That improvement in survival has been the result of many things, including the novel therapies that we've introduced, but also a more timely diagnosis, where we no longer wait until a patient must have end organ damage, but that with the new Slim Crab criteria, we are catching patients prior to that end organ damage. So being at the forefront of this disease and capturing it before others can capture it becomes fundamental. The primary care world is really at the forefront of multiple myeloma in recognizing the early signs and symptoms of the disease, matching that with the right testing so that our patients can have a timely diagnosis, which will influence both their quality and quantity of life. Health disparities is such an important topic in all aspects of our life. But I could make the case that multiple myeloma is actually the most disparate cancer within the African American community. Not only do we know that myeloma is twice as common in the African American community, sadly the most striking fact is that mortality is twice as high also in the African American community when compared to white Americans. This is simply unacceptable, and we have to find ways to reduce that health disparity. We know that African Americans are in fact less likely to have high-risk multiple myeloma and are more likely to have standard-risk myeloma by the presence of things like the translocation 1114. This actually makes the disparity greater, as we would anticipate based on that biology that African Americans would have a longer survival with multiple myeloma. Myeloma-specific health disparities include delayed diagnosis. We know that the average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before myeloma is diagnosed. That delay is even longer within the African American and Hispanic communities. Much of that has to do with trust in the healthcare system, access to the diagnostics, and access, frankly, to primary care. So delayed diagnosis is a big driver in health disparity in multiple myeloma, but as is access. And access may be the greatest disparity. We know, for example, from large VA studies that when individuals are given the same access to therapies, as we would expect in the VA, that patients independent of race and ethnicity would have the same access to therapies, that African Americans actually have a superior survival to white Americans. But sadly, this is not true in real-world evidence and in real life. And reducing that disparity becomes absolutely fundamental. That access is manifest in multiple arenas. We know that there are multiple treatments and approaches that have changed survival of myeloma. Often I summarize them with the 4 T's of access. Triplets, meaning 3 drug combinations that we know are superior to 2 drug combinations. And sadly, African Americans are less likely to access triplets. Transplants or autologous stem cell transplants. We know that transplants significantly prolong progression-free survival in patients, and unfortunately we do see reduced access to transplants within the African American community and also within the Hispanic community. The 3rd T is clinical trials. Not only do we know that clinical trials pave the way to new therapies, they clearly have an impact on patients' outcomes. And for a whole host of reasons, African Americans are less likely to access clinical trials. Indeed, in our myeloma world, African Americans comprise somewhere around 6% of participation in all clinical trials, whereas African Americans account for approximately 20% of all myeloma patients. And the last T is the most recent T, CAR T-cell therapy. This is really a tremendous new modality that we have in myeloma that has had unprecedented response rates, and again, unfortunately, has been less accessible to those with lower socioeconomic status and African Americans. Putting this all together, we see a tremendous health inequity in multiple myeloma in African American patients, and why it's so important for us to be dedicated to the multi-level solutions that will be required to reduce this health inequity. As I've described, the health disparity in multiple myeloma is incredibly complex, and so it is going to take complex solutions. But specific to multiple myeloma, in that delayed diagnosis and reduced access, it is critical that we engage this community. And that deep community engagement, both in the medical and the non-medical world, to raise awareness around multiple myeloma so that those early signs and symptoms can be understood, so that patients can go see their primary care providers to see whether or not they have multiple myeloma, is really going to be important. This is not a short-term strategy, but a long-term strategy. But also, we need outreach into the medical community, into the primary care community, to educate so that we can know what are those early signs and symptoms of multiple myeloma, so that we know how to make a timely diagnosis with the right diagnostic testing. And then lastly, within the hematology oncology community, to recognize that we want to provide the most culturally sensitive and appropriate care possible, that we reduce all of those barriers that have historically kept individuals from accessing the healthcare system and accessing the treatments that we know can improve their lives with multiple myeloma. Thankfully, there are many resources available regarding multiple myeloma. At the International Myeloma Foundation, we've created our website, myeloma.org. And at that website, there'll be many resources, both for patients and for providers. For patients, they can learn the basics of the disease. They can learn to be connected to a support group if they wish. They can learn about our info line that can answer their patient-specific questions. But also for providers as well, there's an opportunity there to learn more about the disease, to understand the diagnostic criteria, the scientific papers that have been created by the International Myeloma Working Group, and many other features are available there in all the areas in which the IMF works in research, education, advocacy, and support. If individuals are interested in learning more about health disparities and how at the IMF we're seeking to overcome those health disparities through the Empower program, where we're empowering patients and communities to change the course of myeloma, similarly, they can go to empower.myeloma.org, where they can see this movement, both national and city by city, to understand what resources are available for community engagement, for education of the primary care world, and indeed education of the hematology-oncology world. In addition to these resources on websites, there are of course several publications and recent publications that have explored the importance of a timely diagnosis of multiple myeloma and how myeloma, being more common in certain populations, should be evaluated more carefully in high-risk populations. In particular, we recently published an article in the American Journal of Medicine as a primer for primary care providers to recognize and diagnose multiple myeloma. And of course, there are many more websites. Our industry partners and others have created websites that can help the primary care provider and all providers in helping arrive to a more timely diagnosis and providing the support to our patients that they need.